They both work. So thank the organizers for inviting me. I'm going to try to combine two talks. Both Jerome Galland's talk on a proposal for new classification of cancer in an era of immunotherapies. And I will make this a little shorter, as we've heard a little bit about this yesterday, as well as earlier today, and from Alessandro's presentation. And then a little bit on the strategic view of Immunescore, specifically how the Society for Immunotherapy of Cancer has decided to push ahead to try and validate Immunescore as a prognostic biomarker in patients with colon cancer. So this is the reason that Jerome is not here. This is Victor, his son, and this is Marie, who's the mother who gave birth to Victor, and the father. Salute Jerome. So Jerome has done more than give birth, along with Frank Bages on this Immunoscore initiative, but he's done something else, maybe even more productive. Well, no, probably not more productive. Well, maybe. I won't debate that. I would like to point out, though, that I do have some potential conflicts of interest, and that I have served in consultant or advisory roles, and I'm about to do some other work with those companies. And I do have ownership and leadership position in UBVAC, which I co-founded 7 years ago with one of my colleagues, which has a phase 2 clinical trial starting. So there's an observation that advances in enumerating immune cells at the tumor provide significantly better staging of patients with colon cancer. And this appears to be a prognostic factor, which is what we're in the process of trying to validate. So, but why is this a prognostic marker? So the hypothesis that some of us have, me in particular, but that the immune system is the agent that improves outcome and cures people with metastatic solid cancer. And I think this is what I teach first-year medical students. I think that it's very important to have chemotherapy and surgery and radiation, but if people don't have an immune system that's seeing their cancer, they're going to have a bad outcome. So that's the overall hypothesis. So what is the basis for this? And I think there's a long history in the immune system and cancer. And it goes back to the early 1900s in Ehrlich, when he suggested, with really no data, that the immune system decreased the prevalence of cancer. And it was only a few short years later that Coley injected the first patient with toxins that led to the regression of some cancers. But it was really, 50-some years later when Prenn in Maine showed what I think is still like the earliest definitive evidence that, in fact, the immune system against cancer can lead to the rejection of cancer with some very elegant controls. So that was, again, all in mouse. But then it was 2 years later that Thomas first proposed immune surveillance in an editorial that he wrote. But then we went through a very great period in tumor immunology, not unlike many of the periods we've had in tumor immunology, where there was this concept that the immune system played an important role, but there was lots of arguments against that. And I won't go into all of those. But in 2001, a paper by Shankaran, coming out of the work of Lloyd Old and Bob Schreiber, really showed, it made sense of a lot of the other data, and showed that there was a critical role for interferon gamma and lymphocytes in tumor development. And that was followed up by a paper on immunoediting in 2004. So I think probably everybody here knows this story, but I will go through it rather quickly. That the idea is that over our lifetime, we're exposed to, I don't know where my pointer is going. Okay, but at the top right-hand corner up there, can you see that? I'll go this way. I mean, I got a red light. Is it not? Okay. Green light. Perfect. Thank you very much. So you've got normal tissue. You get exposed to carcinogens, viruses, radiation. You get cells that become transformed. In that process, they express new determinants, tumor antigens. They may express danger signals, other things. That leads to the generation of immune response against that tumor and its elimination. And for all those of us that haven't had cancer, that's what we think happens, right? That this happens, and in this process you eliminate your cancer. But for some, the elimination is not complete, and it goes into a point of tumor dormancy where there's some equilibrium between the immune cells keeping the tumor cells in check, But at this point in time, we have editing going on where cells that lose antigens or lose MHC will escape, and you'll have tumors grow out. So just focusing on this area, is there evidence that this happens with human tumors? And I think that was the point of Alessandro's just talking about tumor buds and things. But of course, there is evidence. And I think that evidence comes from some of the work that Jerome Galland has done. We're showing that immune cells are present at the tumor site. And here we're looking at a biopsy of colon cancer where you can see the brown cells are CD3 and the blue cells are the tumor. And what they brought to this technology, because pathologists have known for 40 years that the more cells you have in a colon cancer, the potentially better prognosis those patients have. But what they applied was digital pathology and used this technology to objectively assess the immune infiltrates and localize it. And so if this is, and in fact this is from a paper Halama and now in Clinical Cancer Research, but essentially you can take this slide, put it into the digital imager, and then analyze with software to figure out whether or not the cells are present at the invasive margin or within 500 microns of the invasive margin or in the center of the tumor. And so in this way you can quantitate fairly precisely the numbers of cells. And when you do a correlation with optical evaluation, and here we're looking at CD8 counts, taking pathologist's trained eye and the digital imager, you can see there's very good correlation between those two. So applying that technology to colon cancer, what Jerome showed, and this is a paper now that was published in 2006. So you're looking here at the AJCC, UICC, TNM staging mechanism for stage 1 in red, stage 2 in green, stage 3 in blue, and then stage 4. But you can see for stage 1 and stage 2 cancers, you're somewhere at 24 months, you're somewhere up around 92 or 95% for stage 1 and maybe 87% survival. But when he went ahead and broke it down by looking at counting both CD3 and CD45RO, and this also worked for CD3 and CD8, but you can see now you can convert these stage 1, 2, and 3 patients for the 1 and 2s to be above 95% out to about 30 months. And you can see that some of those patients are surviving long term. In the stage 3, you're converting from about 60% to about 80% long-term survival. And I think the other interesting part is those are with the patients who have got high levels of CD3 at the center of the tumor and high levels at the invasive margin, as well as having high levels of CD45RO in both places. Patients who don't have those cells present in their tumor, those are the patients who progress rapidly. So this is the strong evidence, I think, in favor of the Immunoscore being something that should be used as a biomarker. So I think this data really was the next step in this process and showing that it was relevant to patients, to cancer in patients. And then we went through a period of 4.5 years or so where there were no a large series of patients analyzed. And so here you've got 599 patients from the same group, in this case from Melnick, but Jerome Galland is now the senior author, and a paper published in February of 2011 showing this correlation that was similar with what he had shown in Science. But if you look now in this multivariate proportional hazard Cox analysis among all patients with stage 1, 2, or 3 colon cancers, you can see that when you look at the log-rank p-values, that things like tumor stage, which are what we're using to separate these patients now, that this becomes non-significant. And the same with gender, stage, end stage, total number of lymph nodes, histological grade, occlusion. Only perforation remains significant, and then immune score is also highly significant. And this is true for both disease-free overall and disease-specific survival. You can see that immune score is highly significant in this study. And when you look at the receiver operating characteristic curves for this, you can look at both sensitivity and specificity. You can see that the immune score is very good in terms of both its sensitivity and specificity, and comparing that now to the TNM classification there, or even perforation. So that led to Dr. Desis, who talked just before the lunch break, her and her colleague, Dr. Prasad, doing an editorial, which if you haven't read it, I highly encourage you to read it, that the TNM staging in colorectal cancer, that the T is for T cell and M is for memory cell. So what's next? That was now almost 2 years ago. Could these data be reproduced, and who would organize this global effort? And last year at this meeting, we had looked around. We were looking at the pathology organizations, looking at the companies. There was nobody who was pushing ahead with the validation of this effort. And so the Society of Immunotherapy went to the board, and the board essentially allowed us to move forward with this idea of trying to put together a global effort to validate Immunoscore in colon cancer. That was in November. In December, we had a meeting that both Paolo Ascerto and Jerome Galland had organized, as well as the SITC leadership, to buy into this and to set up the parameters. We got NCI agreement on this proposal, and in January there was the first editorial published on this. In February, we had a meeting in Naples to bring together pathologists to discuss key parameters and to build consensus on digital imaging, because this is not a foregone conclusion. Many in the pathology field don't feel comfortable with the digital imaging, but the digital imaging is moving forward. And to set the parameters on CD3 and CD8. So while CD45 and CD8 were used, CD45RO and CD8 were used in that clinical cancer research paper, or JCO paper, that CD45RO is not quite so stable in long-term specimens. So since CD3 and CD8 were about the same as CD3 and CD45RO, the focus was set on CD3 and CD8, and agreement was reached. So that was in early February. Then in late February, the World Immunotherapy Council got together. So this was the meeting in Naples, and then this was the group that got together in Curacao, but it was representatives of 16 societies. And the first initiative that the World Immunotherapy Council has endorsed has been this idea to move forward with the Immunescore initiative. So as of this month, there are now 16 countries participating in this study. There are 22 centers, as Alessandro had talked out. And I think what's interesting about this study, I think all of us think about colon cancer, and we think about things like the microbiome projects that are ongoing, and how might the microbiomes of people in this part of the world and this part of the world differ from people in this part of the world, and even the Middle East. And so we'll have that, as well as genetic diversity, that we'll be able to look at, we hope. So the goals are to validate Immunoscore as a prognostic biomarker, and then really with an eye focus on validating it and moving to set up a new classification for colon cancer. And so really that's the realm of the AJCC, but that's our goal, and I think that there's interest from the AJCC in actually supporting that. The hurdles to us doing that have been substantial, actually. While industry has expressed interest in this, and I've spoken to our industry council at ESCO and to many other in industry, we've not been able to raise support from them or even from the NCI, even though it was judged very highly. Franco had a proposal. There's been no support. So the individual centers are bearing the cost for this currently. SITC is providing the coordination. Control slides have been cut. So Alessandro Ugli, who you just heard speak from Bern, has cut slides for all the 22 centers on 3 different patients that will be used as controls. Staging is set to start in November at a majority of the centers. And then the idea will be that potentially SITC could support a data cloud with images that would be available to these centers, but ultimately to the community to look and be able to potentially investigate other components of that. So Immunoscore, how is it defined? For colon cancer, and I underscore colon cancer, we're looking at CD3 and CD8. For other cancers, I don't think yet we have enough data to know in terms of evaluation of other cell types, other immune cells, evaluation of other parameters, and it will require additional research and validation in large cohorts. And maybe not as large as the one that we've undertaken, but I think in large cohorts. So what about other cancers? There is an association between immune infiltrate and outcomes reported for 18 cancers. I don't expect you to read any of this, but this is from Wolf Friedman's paper, and Jerome is a senior author from Nature Reviews Cancer. But it shows that in 18 of the 20 cancers they've looked at, including all the major players, there is some association between an immune score, an immune phenotype, and outcome. So as we think about the immune score in the future and what it might look like, because again, Alessandro pointed out with liver metastases, a liver metastasis is going to look very different than a primary colon cancer, or may look very different. So the question is what are the other immune players and how might they play a role in other elements of the tumor that might also play a role in this immune, defining the immune context here in the future. And so it's certainly likely to be complex. Will we be able to use gene signatures in parallel with this? Are there other questions, other scientific questions that might be addressed in these studies? So the basic premise that Jerome has proposed and Frank Pages and his colleagues is that the immune response slows tumor growth. And so this immune reaction prevents tumoral extension. And it just underscores the importance of a natural, coordinated, anti-tumor adaptive immunity in humans, regardless of the local extent and spread of cancer. So I think this is really why it's important. So strategically thinking, what are we supposed to do for the next decade? I think really defining Immunoscore in other histologies is going to be important. That may or may not take a decade. But can gene signatures and Immunoscore be combined to further improve a biomarker? One of the points that Nora brought up today was, can a blood-based assay be used to characterize Immunoscore? Are there other ways to assess that? Can imaging studies be used to assess Immunoscore? And I think there's some creative ways that people are looking to address that, including Margaret Crittenden at our institute. And then why are Immunoscore negative patients negative? And what are we going to do for the negative patients? I don't think anybody's going to plan to give up on that cohort of patients, but if they're the bad actors, we're going to need really innovative protocols for these patients that are identified as unlikely to respond. And I think an important question for us in this new age of immunotherapy and the successes that we're having is, we don't know the answer to this, but if Immunoscore negative patients do not make immune responses following immunotherapy, what does that tell us about our ability to prime anti-cancer immunity and the state of our agents? So in terms of checkpoint blockade, co-stimulation alone, I think if that first part is true, that I think it's going to take a whole new next generation of vaccines, because it says we're not doing a very good job of priming our adaptive immune responses. So I'd like to thank all these people. This is an editorial that was just published, which now brings together the pathologists and immunologists at the 22 sites that are actually participating in this, and all the folks here, which this is one of Jerome's slides, which just talk about the people that have supported his efforts to bring Immunoscore effort to where it is today. So I'd like to really thank Jerome for his vision, and all the pathologists and other teams that are pushing ahead with this, who believe that the immune system is really critical, and they're putting a lot of their own time and effort into this. And I just hope that as it moves forward, that we'll be able to find more support from people to help us with this effort. So I'll stop there.
My question is, we learned earlier this morning that different therapies will affect what the tumor microenvironment looks like. So my question is, when is the best time to assess the Immunoscore? And would you do it multiple times during the course of a patient's treatment history?
That is a great question. I mean, these are all being done on patients prior to treatment. But I think how treatment changes the Immunoscore, and how you might be able to influence infiltration of inflammatory cells at a tumor site, are all really critical questions. And I think that's points that people will have to address in the coming years.
Maybe a rather obvious question for me, since I gave a talk today. What about including epigenetic markers into the Immunoscore?
Yeah, no, I was there for your talk. I was going to add that to my slides too, but I think that's the whole point is right now, if we get a biomarker that's got, I mean, the ROC curve looks pretty good already, but what could you do to make it better? And as we move to other cancers where maybe the ROC curve won't look as well as that one does, what should we be adding? And I think those are great things to do. And I think the idea of scheduling it, so your question sort of plays into the previous question of what we heard about people with Drew presenting this morning on agents that might change that, and then coming back and giving immunotherapy and seeing a better response. Those are all things to be looking at, times when you might look at the Immunoscore or the tumor microenvironment. Thanks.
Mine's not really a question, just a comment. I'm really excited about the Immunescore, and I really appreciate that you guys are putting so much effort into it, and I'm very optimistic that it's going to just change the way things go in the next 10, 15 years, and I appreciate it.
Thank you very much. And I think I appreciate all the people that have stood behind us, including the board of the society, because this is an effort that I think the reason that nobody really went forward with this, even though it's been out there for 6 years, is that they're not the real believers. And I think it's the people in this room who, most of us have probably drunk the Kool-Aid and have believe in the immune system and its critical role. That's why we're doing it. This Immunotherapy Society is doing this. Yes?
It seems to me, valuable as the Immunescore is, that one piece that's missing from most understanding of tumors is a complete list of the cells that actually comprise the tumor. And it's striking that at a time when we know so much about the molecular and physiologic mechanisms that occur, that we have really an incomplete list of the cells that comprise and the number of each type that comprise a tumor.
Right.
And as you think about the Immunescore, it may well be not just the number of cells, but the concentration of one cell type versus another that gives us important information. And without sort of a baseline of different types of cancer, we're going to have a hard time interpreting the data.
And I agree with you, and I think that it's the application of technology and digital imaging that will allow us to quantitate these cell types. And so that's really an important component. I think prior to this, old school pathology, 1+, 2+, 3+ fluorescence, would never let you do this. To be able to assess the cells per millimeter square within 500 microns of an invasive margin and look at the ratios of those cell populations in a way that's objectively identified and characterized, and that you could do repeatedly, and you could potentially, you heard just, Alessandro just briefly talked about this idea of these high-density arrays, but you can imagine having those sorts of arrays be able to grind through some of these really, lists of markers to characterize the tumor microenvironment.
So an important thing to, I think, to include then in the number of cells per square millimeter is the thickness of the section. Because without that parameter, one can never calculate the concentration in 3 dimensions. And that's really the key parameter. These are not 2-dimensional objects, and you can't do biology in 2 dimensions. So if I would add something to the Immunescore, it is that the Immunescore be created so that it's the 3 dimensions that we have control over, so we understand exactly what it means. Otherwise, your 2 millimeter square Immunescore won't correlate with anybody else's 2 millimeter Immunescore because the sections may be a very different thickness.
I'll defer that ultimately to my pathology colleagues who've been discussing this back and forth. So, go ahead.
Is that a rule? It's always 4 micrometer section?
That's what she said, and that came from the lab that is coordinating it. Yes.
Bernie, it's great to see this effort underway. What kind of discussions have you had with the AJCC about this, and are they involved in these meetings?
So Howard Kaufman has been talking with the Commission on Cancer, and about issues related to this. So I don't want to say more than that, but discussions have started at some point, unless Howard's here and wants to comment. But
since immunohistochemistry is limited by the number of good antibodies for immunohistochemistry, I think it would be really useful to the field to also keep a running score of the several hundred molecules of potential immunological interest, which ones have defined a good immunohistochemistry antibodies, and which have been tested for the Immunoscore, so one knows what's been analyzed and included or excluded.
And that's a great thing. As moving forward, I'm hoping that the SITC website, when this cloud computing capability that we've talked about uploading things, will have all these slides available for people, one, as well as all the protocols, which are already on our internal Basecamp site for all these 22 sites. But our goal would be to make all that available for the whole community to be able to assess this, and then ultimately have a company come in and sell a kit. That would be this sort of a way to standardize it. But for the researchers, we hope to have all this available soon. I should probably stop. Cut me off.
on this incredible wealth of data focused on CRC and the importance of the Immunoscore there, to me seems a bit ironic that when you look at the success of clinical trials with immunotherapies, the colorectal cancer sort of drops at the bottom of the list.
Yeah.
You don't see responses to speak of with CTLA-4 blockade, PD-1, PD-L1 blockade.
I think there's one in PD-1, I think. I don't
Well,
remember that
that's
much,
what it's the exception
yeah, it's the
that sort of
exception.
stands out, that it's not like what you see with renal, lung, melanoma.
Right. I agree with you, but I guess it's sort of also on a continuum of time. You know, if you start to think about this, the triple E, so elimination, equilibrium, and escape, where are those tumors? So even if they were earlier maybe being kept in check, so it depends when you get to them, when they're finally getting immunotherapy. Are they so advanced that, in fact, it's beyond the point when you should be using the immunotherapy, or there's so many escape mutants that are out there that you can't control them? But that's a great question, and